present a topic on the approach to failure to thrive. First, start with a case. A 2 months old male patient presented with loose rashes all over the body, bilateral pedal edema with some dehydration. Due to the less production of milk, due to poor family condition, the patient was on sugar candy water for last 7 days. On examination, it was found that the wasting of the muscle at the loose skin folds and the perianal exfoliation with the hyperpigmentation of the skin was present. And after plotting the last 3 weights and the length of the baby, the growth chart, we found that all are below the 5th percentile. Below the 5th percentile, and the patient is suffering from failure to thrive. Now, what is failure to thrive? The failure to thrive, this term is not a diagnosis. Mostly this is descriptive. The term is mostly used for infants and children less than 5 years old. And the physical growth is significantly less than their peers of the same age and sex. The failure to thrive, this is described under the persistent weight loss and failure to gain weight or fall in the rate of the growth from the child normal percentage. The criteria, these are the criteria which should be, any one of these should be fulfilled to say that the child is suffering from failure to thrive. Mainly the weight for age less than 5th percentile and the weight deceleration crossing to measure percentile value. The epidemiology, around 5 to 10% of the children in the primary care setting suffering from the failure to thrive. As per the National Family Health Survey, using the World Health WHO growth standard, around 19.3% child under 5 are suffering from the failure to thrive. And this chart shows that around 35.5% child under 5 children are stunted. Around out of 3, 1 child is stunted in India. The severity of the failure to thrive. The methods present wait for the age, the Gomez classification. The severe failure to thrive when the weight for age is below 6%. In the Wellcome classification, the height for age is when the less than 85% child and the weight for the height is less than 70%. The McLaren classification, the present weight is to height by median weight is to the height of that age. If that is less than 70%, then it is for the severe. The classification of the failure. Traditionally, the failure to thrive is classified as the non-organic and organic causes. Based on pathophysiology, this is also classified as inadequate calorie intake, inadequate absorption into calorie requirement, and the defective utilization of calories. The non-organic cause is the most common cause. Around 80% cases of the failure to thrive uh, is due to the non-organic causes. And in non-organic causes, the main poverty, lack of knowledge regarding the feeding practice is the main cause. And the psychosocial factor is also uh, a major factor. In organic causes, uh, the, in cardiovascular disorder, there is the congestive cardiac failure, pulmonary arterial hypertension, cyanotic and cyanotic heart disease are there. And respiratory disease, cystic fibrosis, asthma, bronchiectasis, gas, gastrointestinal disorder, malabsorption, bowel disease, in neurological disorders, cerebral palsy, intellectual disability, CNS abnormality. In renal disorder, the renal tubular acidosis, renal failure, endocrine disorder, hypothyroidism, and hypothyroidism. Most common. The chromosomal abnormalities, Down syndrome, Disorder syndrome, metabolic disorder, inform error of metabolism, cystic fibrosis, Curis disorder, mucopolysaccharidosis, the, the neoplasm, the malignancy, and the CNS tuberculosis, AIDS, infection in the GI tract, the infectious main causes of the infection. And in the immunodeficiency cases, also the failure to thrive, one of the most common presentations. Cause of failure to thrive according to the pathophysiology, inadequate calorie intake, the poor feeding and the breastfeeding problem is the most common cause. Inadequate calorie absorption, the malabsorption syndrome, chronic diarrhea, celiac disease, pancreatic insufficiency. The defective utilization, the chromosomal abnormalities, trisomy 21, 13, and 18 is there. Excessive calorie requirement in cardiac problems, cyanotic heart disease, cyanotic and acyanotic heart disease, congestive heart failure, pulmonary system, the severe asthma, chronic respiratory failure, renal system, renal tubular acidosis, and in endocrine system, hyperthyroidism and the diabetic. The evaluation and the management, the thorough history taking and the physical examination is the main cornerstone. Evaluate the failure to thrive. In the history taking, we have to take the prenatal and the birth. If there is any birth asphyxia is present, or the child is IUDR, or preterm delivery is there or not, we have to know that. In family history, if there is the height of the mother, height of the parents is there, or any previous child failure to thrive is there or not, any history of the abortion is there or not, that is also important. The developmental history is also important. If the child has any developmental delay, the neurological problem is there or not. In social history, the per capita income, the per capita income, and the literacy of the parents is very important. In diet history, in this also the literacy of the parents is also important. The diet is the adequate diet is the child is taking the adequate diet or not, and the concentration of the meal is adequate, right or wrong, is taken into consideration. In the physical examination, uh, the hypotension is seen in the adrenal and the thyroid insufficiency patient. Hypertension is we can see the renal disease. The tachypnea and tachycardia is seen in the increased metabolic demand is there. The pallor is present or not, breathing is present or not. In our case, the patient was cachectic and there was pallor present in our cases. And also the inadequate adiposity is there. The dysmorphic basis is very important for the genetic syndrome of this. Microcephaly, in the microcephaly, the neurological disorder in an fetal alcoholic syndrome, the microcephaly is there. The delayed closure of the frontonale is present with the vitamin D deficiency and the hypothyroidism. Short palpebral fissure and short palpebral fissure smooth philtrum is present in the fetal alcohol syndrome. Cataract is present in the congenital infection, keratosemia. Papilloedema is present in the increased ICP. Quiz tackles and the prolonged expiratory phase is present in the cystic fibrosis, cardiac murmur. In malabsorption, we can get the abdominal distension and the hyperactivity. Bowel is there. In the endocrinopathy, the genitourinary abdominalism is there. In Crohn's disease, the rectal fistula, large perianal, the perianal skin tags are present. Perianal skin tags are present. Congenital adrenal hypertension. In the musculoskeletal and the neuromuscular and the mucous membrane, the clubbing is given in the chronic hypoxia due to cardiac and the pulmonary disorder. That indicates the bony deformity is present. Protein deficiency, there is protein deficiency. Edema is present in our case. The edema was present. In immunodeficiency patient, candidiasis, the other opportunistic infection can present. In iron deficiency, infect, male, we can see. In the laboratory studies, the initial study, the complete hemogram, the reactive protein site segmentation rate, in estimation, the primary investigation. We have to do this is the primary investigation. Urinalysis and culture of the skin for the protein and carbohydrate. Kidney anomalies there or not. And we have to do the electrolytes creatinine for the kidney disease. For school, we have to if there is any gastrointestinal infection or infection is there, we have to do the stool study, the routine culture, and the ova parasites of the smear. We have to do that. And the chest radiograph and the echocardiography we have to do to rule out the cardiac and pulmonary causes. These are the advanced states we have to do in the next level. The for food allergy, the serum immunoglobulin, the serum IgE, and in the IgE we have to rule out the food allergy. Gastrointestinal disease to rule out the celiac disease, the primary investigation that is done, vitamin and the serum IgA level, we have to check that. In the malabsorption syndrome, the stool, the protein, alpha 1 antitrypsin level in the stool, and the stool elastase, we have to see in pancreatic insufficiency. For Helicobacter pylori, a stool antigen assay or the 13C nuclear test. In inflammatory bowel disease, the occult blood test, fecal calprotectin, fecal lactoferritin, fecal leukocytes that is present or not, you have to also see that. In gastroesophageal reflux, the esophageal pH and the impedance monitoring to rule out in gastric reflux is present or not. Swallowing dysfunction, swallowing function study to rule out if there is any swallowing dysfunction, is there or not. The vomiting related to the intra-abdominal or intracranial due to intra-abdominal or the intracranial cause, because we have to do that. The inborn error of metabolism and the endocrine disorder and the endocrine disorder, we have to rule out the hypothyroidism, growth hormone deficiency, the infectious disease, the hepatitis, TMT, tuberculosis. We have to also in the treatment part, the nutritional rehabilitation, non-organic causes 80% for the nutritional rehabilitation, the mainstay of the treatment, the dietary management, therapeutic trials for the patient, adequate in the calories, and the fluid and the protein, and we have to give the adequate food and the protein the child. The child should reassure on the reassure after 2 months. Solid food to be given before giving the liquid food. The child should be allowed to decide the which food he or she wants, and the food with high calories and protein should be provided. And we have to also do the treatment of the organic condition that is present. Management of there is also the psychosocial issue, is a very big problem for the failure to thrive. So we have to support the child from the family and the friends group. The problem in the family, there is conflict, marital conflict is there. We have to properly counsel the parents, and we also have to change the environment for the patient. The indication for the hospitalization. The severe cases of the failure to thrive, severe cases, we have to hospitalize the patient. And in mild and moderate cases, the child is not improving in spite of given treatment, then we have to treat the patient. And in case of child abuse and organic cause, there is organic cause, we have to evaluate the organic cause, we have to admit the patient. For severe failure to thrive requires the high energy diet along with the micronutrient and vitamin, and around 150% recommended daily calorie needed for the catch-up growth of the patient. Iron and zinc should be supplemented to the patient, and the zinc should be 0.3 milligram per kg per day. calorie density of the human should be increased with the human meal 45. The child more than 1 year of age should take 3 meals and 3 snacks in one day. The beverages should be avoided. We can also use the cyproheptadine as the appetite stimulator. Pudding. Food in study. I don't mind the king. King. The estimated energy requirement for the age 1 to 2 months, it is the 100 energy requirement. The complication, the most severe and the potential fatal complication in the repeating syndrome. Repeating syndrome, in this case, the hypokalemia and the hypomagnesemia, hypophosphatemia is there. So we have to gradually increase the feeding of the patient. If there is refeeding syndrome happening, then we have to reduce the calorie intake of the patient by 75%. And prognosis. Due to sudden increase of the energy, prognosis depends on the following factors: age of the onset. The younger the age of the onset, the more the complication is there. Duration of the failure to thrive, the prognosis is good. If the duration is short, the predisposing condition, child is decreased with nutritional intake increased to the proper nutrition. Few children of the psychosocial cohort may gain weight slowly, but in the later life they develop the antisocial behavior. And conclusion, failure type is a descriptive term, not a specific diagnosis. Results in inadequate usable calories necessary for the child's metabolic and growth demand. Simplified approach failure to type detailed history and physical examination of the primary caregiver. Initial investigation including urine culture, food for ova and food of the parasite should be done. And the trial of the nutrition therapy with the calorie dense diet